Professor Vishali? It's okay. So we've now got Professor MANGAT DOGRA, who's done so much work on diabetic retinopathy and also ROP and retina. He's been a teacher all his life, and we both did our fellowships in the US. So we had a great time. We were in the US. Besides work, we also used to go out on the weekend to the harbor at Baltimore. So we had a good time learning, and so I know him very, my guru and my very close friend. So he's going to tell us about recalcitrant diabetic macular edema. How does he manage? What would be his experiences and his approach? So you would learn a lot from what he says.
Thank you very much, Dr. Atul, for your kind words. I think we have had a great association, as he said, and I'm thankful that you invited me for this course. So I'll share, I do have now financial disclosure for Bayer and Allergan, because sometimes I'm their speaker or an advisor. And so I think straight away I'll go on to the recent DME classification. I think that is what is very important. There are so many classifications in the past. I think it's very important to know that these days it is center involved as shown here or non-center involved, because the whole management, the strategies depend upon that. So that's how it is mostly on, you see, OCT that you're going to have this kind of a classification. You can see the intraretinal fluid there, but it's away from the center, so this becomes non-center involving DME. So just to give you a little recap, I think whenever you get a case of diabetic macular edema, always do these investigations first. Don't rush with the treatment. And once you have done all this, blood glucose level, blood pressure, their total lipid profile, also hemoglobin, they are mostly anemic, and also doing HbA1c. And one thing which I have seen, everybody orders blood urea serum creatinine. This is the biggest mistake. This is very late, parenchymal damage. Please get their microalbuminuria, 24-hour urine protein. That is how they'll do well. And this I have seen universally. Nobody does. Everybody is happy with blood urea. That will be late. So don't do that mistake. And of course, you take fundus photo, OCT, and FFA. This is from the ophthalmology point of view. So what you want to do is send the patient to a good internist or a diabetologist or endocrinologist to achieve excellent glycemic control, normalize blood pressure, reduce the serum lipids, treat anemia and proteinuria. Everything has to be in a packet. That is what is very important. I'll show you this case here. This is way back in 2005. Just in 3 months, look at it. Just with the good metabolic control, lowering the lipids, improving the sugar levels as well as hypertension, everything, this is without laser, without any treatment. That is what you will achieve. So DME management options, all of us we know. The main management, these are the anti-VEGF agents, which we have 3, ranibizumab, aflibercept and bevacizumab, and laser photocoagulation, which at one time, it is not gone totally. Still you may need laser in some cases later once you have done anti-VEGF. And steroids, we have a DEX implant and triamcinolone. We don't have a fluocinolone or that is not there in our country. And vitrectomy may be required in some DME cases with tractional DME. As far as the anti-VEGFs are concerned, what is very important, and we have all observed this as well as various trials have shown, that you need early intensive treatment with anti-VEGFs in the first year. I think what happens, we are happy with one injection, we don't do it. And then it becomes kind of a PR and come back. No, don't do that. Do an early treatment and intensive in first year, so that in second year, number of injections would come down, as well as they'll do much better. And third year, you will have even much lesser injections. And aflibercept is the treatment of choice for patients with poorer vision. You have 6/12 or less vision. If patient can afford these days with that scheme, whatever they have, it comes to same as any other anti-VEGF. So in this kind of a scenario, if you start as a first line, they do very well. And what is very important, and that is what major topic for me, is that approximately 1/3 have persistent DME or they are refractory despite your anti-VEGF treatment, and they may require corticosteroids. So this is one paper by Sada et al. Here in post hoc analysis, which is published only recently in 2020, where they have clearly shown that 1/3 of patients experienced persistent edema during the first year after initiation of treatment. That means intensive ranibizumab treatment. And this kind of a persisted even later on from 52 to 104 months. So there are studies available like this. The study author concluded that treatment with Ozurdex is associated with a significant improvement of 4 lines in cases of DME which are recalcitrant or refractory to anti-VEGF therapy. So I'll just share you one case here. I think this lady came to me after my retirement in the new center where I work. 72 years, pseudophakic, received 9 Lucentis in one eye and 8 in other eye, also focal grid, in between had MI, stenting. When she came, she was a very unhappy lady. But what she needed probably is, this is typical edema which is chronic, and you give Ozurdex. In fact, we had, I think she's still receiving Ozurdex and she's still maintaining very good vision. But at the same time, I would like to share you this patient. This patient has been with me right from the PGI. It has been 3 years from my retirement, even before that. And we used to treat him with various anti-VEGFs. And of course, on PRN basis, he was never happy. And even we treated him with 2 Ozurdex, with this very eye. And he's 660, 624 here. And this is the left eye, 624. So why I wanted to share this, that why intensive treatment sometimes is required. And maybe at this time the patient could afford, because under the scheme. So thought of giving those, they talk of 5 Eylea injection to be given monthly. And that is what I did to this patient. And this was despite that he has a suboptimal even response to Ozurdex. So you can see how it has behaved with 5 injections. And it has almost, you see, of course, some outer layer disruption is there. But look at the patient. He can now read. He's the happiest patient. He says, I'll take this injection whenever you say. So I think sometimes we do need to do this kind of a therapy where you need intensive treatment monthly. And monthly 5 injection has been now proposed in many of the trials like Apollon and other trials. So this is what finally. And then come to the DME surgery. This is especially required for the tractional DME. You may use initially anti-VEGFs here or even steroids. Sometimes they work. They may work for a longer time. Not all tractional DME may not require surgery also. But then I will share again a lady here. She used to come to me for a very long time from 2009. She received earlier, she won't even agree for injections. So she was receiving lasers repeated in the eye. And then finally, after even receiving so many Avastin, Lucentis, she agreed for surgery. And you can see what happens after the surgery, just with ERM peeling, no ILM peeling has been done. The vision has improved here. Not only this, you can see those old laser scars on autofluorescence, how well she has improved. So there are various kinds of refractory or recalcitrant DME where you'll have to take each case on individual basis. And that's how perhaps if you take, then you can treat them better. There are new therapies in horizon. I'm sure if they have improved, I got a message today only that FDA has improved this brolucizumab for DME. So if we don't have inflammation, this is a very potent drug. This we have seen also in some cases. We use very, very sparingly at this time. And this is longer acting. And faricimab. Also, we are looking at some of these port delivery and gene therapies. So in conclusion, I would say, since my major topic is recalcitrant DME, that 1/3 are non-responder or recalcitrant DME despite your best of management. So there you need a different approach and you will have to treat each case differently. And you must institute good metabolic control in them. Many of them, they improve even once their renal status, other problems are there, they become better. And you require alternative therapy with steroids or prolonged monthly anti-VEGFs, as I have seen. Give them intensive treatment. In addition, vitreous surgery is required in tractional DME, which also I have shown you an example. So thank you very much for your attention.
Thank you so much, sir. Any questions for diabetic macular edema? Yes.
Sir, you said good metabolic control, but sir, I say the other way around. The diabetologists never say, go to the ophthalmologist and get your treatment done, so I don't give a credit to this metabolic control because how would you prove? You see, I mean, I do agree, metabolic control is a must. You send it to your internists, but they just don't pay much attention to that. That's what my complaint is always with the diabetologist. Second point is what you said about the macular edema, only diabetic, but it can be true for any vasculopathies where the macular edema is coming? The treatment modality, what you suggest?
Yes, for various modalities, I think these days you require more intensive therapy. What we are used to and we should not be doing is we are mostly dependent on PR and treatment, which is probably not a good strategy. At least in AMD, it is not at all good because they lose vision every time. But even in DME and even other vascular occlusion, we find if we don't institute intensive therapy, I think they don't do that well. And regarding the metabolic control, which you said, what you should do is what I have followed and we follow. We get these investigations back when the patient is coming to us. And we look again at those investigations at 3 months. That if his HbA1c was 12, 11, we want to insist that it has to come below 8. You see, that is what is important. If his lipids and other things were high, they have to come down. Protein, if there is a microalbuminuria or a proteinuria, you can't eliminate it, but it will come down. So everything you have to see yourself and then instruct and write clearly to your internist. They will do the needful. They will definitely do the needful.
Can you explain the 24-hour urine examination?
Yes, that is what is very important. Because
Can you explain what it is, why does it?
No, they just collect 24-hour urine and look for the entire protein, how much is the protein is coming there. So what we do is, we are mostly ordering for serum creatinine and blood urea. That will be very late. By that time, we have lost the battle. So please, that is very, very important. I have never seen anybody ordering for this. They all the time, please do it. You will benefit these patients much more.
Thank you.
Thank you.
Yes, one by one, please.
Yes.
Thank you, Dr. Dogra, for a wonderful talk. I just want to augment one thing. The brolucizumab, the new drug, we used it sparingly in a few cases of recalcitrant macular edema, as you've shown. And some of the cases, they really did, it worked. And we were really amazed, especially in 2 cases. They had been receiving all sorts of, even aflibercept for years, for the last few years, and 2 injections of brolucizumab brought down all the edema. So I'm waiting for real approvals and the dosage, whether it should be 4 weeks or 6 weeks. I don't know yet, but I think that might be another very good drug that we can use in the future. Thank you.
Yes, we are looking forward to that.
Just I wanted to ask you, while you are getting the metabolic control, do you start off with the antiphages? Because often these patients are having a prolonged macular edema.
Absolutely. Unless you see the sugars are way up, then you don't want to really get into trouble sometimes. But otherwise, you start with anti-VEGF therapy every month intensively, and in the meantime also gets all the parameters down, all parameters, not the sugars. We are habitual and telling just get your blood sugar all right. And they'll show you fasting mostly. And the patient may not eat in the evening, and in the morning the sugar is down. But otherwise his HbA1c will be 11 or 12. So I think that this aspect is often neglected, and this aspect also helps their other things in the body, whether it is going to be subsequently other organ, nephropathy, neuropathy, or even heart involvement and other things happening.
Yeah. So another test the physicians recommend is the ACR,
Yes.
albumin creatinine ratio. That is also very helpful.
Yeah, well, that is further. But if we do simpler things, what I have listed, I think we can really guide patient, and it helps also because they have very good drugs even to reduce proteinuria, and they prescribe particular diet also, so that their proteins you can't eliminate, but you can reduce them.
Thank you.
Thank you so much, sir.